On. Uh, yes, we are all set now. So, all of you are welcome to this 224th edition of Thursday Musings. Today, we'll be talking about focal epilepsy, a practical guide to localization. The meeting is being recorded, will be put up on the YouTube channel. The questions are invited in the chat box. Everyone is on the mute mode except the panelists. So, next slide, please. Uh, Professor Dr. Tufan Pati sir is the chairman of this program since he is in transit. So we welcome him while he is in the mute mode. Next slide, please. Dr. Amrit Patajoshi is a co-moderator. Next slide. Along with myself, Dr. Aleem Siddiqui from Lucknow. Next slide. Dr. Vishal Chhabra is from Delhi. Next. Dr. Shobhit Garg from Dehradun. We are the co-moderators of this panel. So next slide, please. Yeah, so let me introduce Dr. Sriraj. Dr. Vantamir S. Sriraj is Associate Professor of Psychiatry, currently at NIMHANS. He is also our junior from CIP days. So he did his PDF in Clinical Neurosciences and Therapeutics in Schizophrenia. He is DNB in 2012 to 14, DPM from CIP, and MBBS from Tumkur Medical College. He's Associate Professor of Psychiatry at NIMHANS. Previously, he was Assistant Professor there and was post DNB SR, non-PG resident and JR at other places. So, welcome, Dr. Sriraj. You're one of the chairpersons. Welcome to you. Next slide. Dr. Nishant Goyal, he's Professor of Psychiatry at Central Institute of Psychiatry. He is our senior. So, welcome, Dr. Nishant. He's currently Program Coordinator, CIP Digital Academy, General Secretary and founder member of Neuromodulation Society of India. In past, he has been editor of Eastern Journal of Psychiatry, associate editor of Child and Adolescent Mental Health Journal. His area of interest is child and adolescent psychiatry, non-invasive brain stimulation, public mental health, having a century plus of publications, 30 plus awards and fellowship. He's currently in charge of Center of Child and Adolescent Psychiatry, FMRI Center and CCN at CIP and in charge of academics. So welcome, Dr. Nishant. Dr. Sriraj, meeting is over to you and you are the chairpersons now. Please take over. Next slide. Yeah. One of you can introduce the speaker and both of you can introduce the topic.
Sriraj will do the honors. Sriraj, over to you.
Thank you so much, sir. First of all, I'd like to thank the organizers to have me here. Alim sir, Dr. Vishal Chabra, Shobit sir, or my seniors who have been mentoring me and taken me through all this journey through all these years, and including my co-chairperson, Dr. Nishant sir, who has been kind enough to have me as his co-chair here. Honored to be here as a chairperson. And also honored to be part of this webinar, which it's one of the important topics, I would say, the focalizing the epilepsy, which again, I would give all the honors to Nishant sir and my seniors in CIP who kind of introduced me to this topic and made me also interested in it. And I think that's one of the reasons why I am here as well. And I'm pretty hopeful that Dr. Aditya Chaudhary, an eminent neurologist from with training in PJ Chandigarh, who also has done his MRCP and MRCP CSC from UK. He has also done diploma in public health administration, fellowship in neurosonology, and who is working currently as senior consultant of neurology in Manipal Hospitals, Kolkata. I'll be honored to have and eagerly waiting to listen to him and learn more from Dr. Archit Chaudhary here. And I would like to request Nishant sir also to provide introductory remarks on that topic.
Thank you, Sriraj. Thank you once again, Tufanpati sir and the entire team for having me once again to chair, one of the very important topics which are, which we mental health professionals should not be wary of. Dr. Aditya Chaudhary might, consider that why psychiatry people will have to listen to, localization in epilepsy or localization of epilepsy. Dr. Aditya, I would like to inform you that CIP Ranchi has a very unique, disposition of teaching epilepsy and EEG to their residents in MD psychiatry. So we have the facility. We have an epilepsy clinic. I think it's the only center in the country which has an epilepsy clinic where there is no neurologist or there is no neurology. So we have been trained in epilepsy and we train our residents in epilepsy very often. Now coming to the topic, I'm sure as mental health professional, we cannot, as I said, get away from the practice of epilepsy, particularly the interface of epilepsy with psychiatry when it comes to the semiology of seizure. It is very, very important to understand the difference between a seizure or seizure-like phenomenon. At times, non-convulsive status epilepticus mimic like psychosis at times, and they are missed. So it is very, very important for all of us to learn and understand the localization of epilepsy particularly, and the practical aspects of that. Also, we all understand, we all know that long-standing organic disorders like epilepsy, they are associated with various psychiatric comorbidities. So we do come across such cases, such patients every now and then. So understanding the subject, understanding the topic from none another than a trained neurologist would be of great and immense help to all the mental health professionals, I think, who have joined today in this 224th edition of Thursday Musings. So with these words, I think we can request Dr. Chaudhary to take over the stage. Shiraj, you have to say something? You are muted, Shiraj.
Yeah. No, sir, I think we can go ahead. I think.
So
Yes.
I'll request, on behalf of Shiraj, I'll request Dr. Chaudhary to take over from here. Over to you, Dr. Chaudhary. Thank you so much for accepting the invitation.
So
Go
first of
ahead.
all, I'll be thanking the house to invite me to talk on the topic. Though I am not a epileptologist, and I knew that I would be talking to eminent psychiatrists from the country. So epilepsy is one such field which is a very dark area, in which, or a gray area, I must say, which encompasses symptoms which may pertain to fear, psychology like symptoms, autonomic symptoms which might look like psychogenic symptoms, and there is no demarcation whether it should be dealt by a psychiatrist or a neurologist, and it's really overwhelming and gratifying that epilepsy clinic is run in CIP, and so that people can be helped rather than running from pillar to post or finding a neurologist, so that their symptoms can be treated. So, without much ado and thanking the house, I would straight away delve on to the topic. But before that, I would like to make that the one statement that I've kept it really very basic. I have not gone into intricate semiologies. I wanted to keep it more simple, more basic, so that we all revise, because I knew I'm not speaking to a bunch of neurologists. There are some psychiatrists who are still in their training period, so this should be a session which helps them in their training also, and we can deliberate on intricate matters after the presentation. We have the eminent house here, so without much ado, I'll straight away start the presentation, right? So, introducing the topic, we are talking about epilepsy, and we know that they are paroxysmal events, which have clinical symptoms or sign, which is generated by excessive and synchronous electrical discharges of the brain networks. And the semiology depends on the location in the brain, the pattern of propagation, and how actually it is affected by various physiological, state of the person. We have the concept of a generator, but now this concept has changed into networks, which is both cortical and subcortical. And the accurate semiology is very important so that we can localize the area of treatment. Where is the epileptogenic zone? I'll be talking about it. I'll be briefly touching upon it so that we try to understand the semiology as well. And this actually, retrospectively, we try to get it from the patients. And then when we evaluate, we have localized these symptoms to the various parts of the brain. So, a practical definition of epilepsy says that either somebody who has seizures 24 hours apart, or one has one unprovoked seizure and a further probability of seizure, just like a two unprovoked seizure in the next 10 years, that tantamounts to around 60%. Or there is a diagnosis of an epilepsy syndrome. So we need to understand that whereas epilepsy is the syndrome complex, one event is the seizure. So a disease occurring with spontaneously occurring events, which is recurrent and continuous, is actually epilepsy. So, before knowing about the semiology of focal seizures, we should know what exactly is focal seizure. The ILAE, or the International League Against Epilepsy, they have changed the operational definition and the classification of epilepsy in 2017. Now, we have to concentrate that previously the focal onset seizures were classified with and without consciousness, which has been changed to impaired awareness. And the onset of the focal seizures has been changed to whether it is a motor onset or a non-motor onset. Now, people might have awareness along with non-motor onset focal epilepsy. People might be unaware of what is happening with them and have non-motor onset that includes autonomic, behavioral arrest, cognitive, emotional, and sensory. Or they might be motor onset with automatisms. They can be atonic seizures, clonic seizures, epileptic spasms, hyperkinetic seizures, myoclonic seizures, and tonic seizures. We need not worry. I would be delving into each and every kind of seizures, which an accompanying video, so that we can understand what I am talking about, what are the kind of seizures I'm talking about. And then there is the generalized onset, which we'll not touch upon today. And then once we have a patient and nobody is able to qualify what exactly was the onset, whether it started with focal seizures and then generalized, or whether it started from the very beginning as a generalized, then we classify it as something which is whose onset was unknown. So the definitions, other seizure types, and descriptors are listed in the accompanying paper, which is this paper of operational classification of seizure types, is published in Epilepsia. And as I've already said, this can be focal or generalized. The focal again can be with or without alteration of consciousness. So this is actually the essence of what was shown in this slide. So we can easily, deduce what this paper and this classification wants to tell us. So there was change in words or wordings or definitions. Like previous classification, they used to use unconscious, which has been now changed into impaired awareness. There was something known as partial seizures. This is more important for residents because once they read books, they have terminologies which can, be coming from the old classification, or that can be coming from the new classification. So that should not, confuse the reader that what exactly the text is talking about. So what was previously called as partial epilepsy or partial seizures is now focal seizures. What previously was simple partial is now focal aware seizure. What previously we used to call complex partial is now focal impaired awareness. Dyscognitive seizures are focal impaired awareness again. The psychic seizures are now classified as cognitive seizures or renamed as cognitive seizures. The secondary generalized tonic-clonic, we now call it focal to bilateral tonic-clonic. And the arrest, freeze, pause, or interruption, now we all use a common terminology known as the behavioral arrest. So, for example, if I say that a woman awakens to find her husband having a seizure in bed, The onset is not witnessed, but she's able to describe bilateral stiffening followed by bilateral shaking. The EEG and MRI are normal. So according to 2017 classification, we would call it as a, sorry. So we would be calling it a unknown onset of seizure, which is tonic-clonic. Okay, am I audible?
Yes, sir, you are.
Yes,
Yes,
you are.
you are.
Okay. So one thing which is important to understand and define is something which is what exactly is an epileptogenic zone. So it is that part of cortex that is necessary and sufficient for initiating seizures and whose removal is necessary for complete, removal of seizures. If we do not demarcate and delineate this epileptogenic zone, we could be, wrongly treating a patient and let him or her undergo a very a complex surgery without much productivity. The reason being, this is exactly the zone which has to be removed so that the patient becomes seizure free. So if we do not delineate this area, and instead of delineating just the symptomatic zone and treating the symptomatic zone or removing the symptomatic zone for treatment of epilepsy surgically, then we would be landing up in the wrong side. And so we have to remember that the epileptogenic zone is that zone which encompasses all the areas which needs to be surgically removed so that the patient is rendered seizure free. So epileptogenic zone and symptomatic zone has to be differentiated and has to be understood that they are not one and the same thing. So the area whose activation produce the ictal symptoms can be the symptomatic zone. But now we need to understand that the onset zone may be asymptomatic and it may propagate to an area which is symptomatic. So the symptomatic zone will be showing us the symptoms. However, the ictal onset zone will not be showing the symptoms and we might miss that area to remove it surgically. And so we may not render the patient seizure free even after removing the symptomatic zone. So it is the entire area which is being encompassed, which has to be removed to render the patient seizure free. Then now, what is the irritative zone? The irritative zone, we know that the positive predictive value of EEG is pretty less. We need to do EEG around 7 to 8 times sometimes. The more we do the EEG, we might find something positive through the number of times we do the EEG. Most of the EEGs might turn out to be normal. So between the episodes, whatever interictal changes occurs, the spikes occurs, that occurs due to the irritative zone, which might not manifest, but they are the reason for the interictal, discharges which presents in the EEG when the patient is normal. Many times it is difficult to understand that interictal spikes, the patient can be absolutely talking to you even when the patient is having an interictal spike. Now, what is a functional deficit zone? This area is whose activation or deactivation leads to neurological or neuropsychological deficits, for example, verbal memory impairment or the Torch paresis. So this is the pictorial representation of what I am just talking about. So this is the ictal, onset zone, and this is the epileptogenic zone, and this might be the symptomatic zone. So in doing the imaging, we need to know that whatever macroscopic lesion that is causative of the epileptic seizures, like something known as cortical dysplasia, or which leads to secondary hyper excitability of the adjacent cortex, that needs to be removed. So how do we exactly find out or delineate these different zones? Most commonly, which is available to us in most of our centers, are EEG and a 3 Tesla MRI, which does MRI with the epilepsy protocol, because they change the interslice thickness. And some institutions also do have spec level, but we do not get the spec in private practice. And MEG is still not available throughout the country. It's a it's available in 2 or 3 centers. I am not aware about more centers which has come up with magnetoencephalography. So these are the various investigations which can be done to define the various zones. For the residents, we need to understand that MEC stands for magnetoencephalography, and it employs magnetic waves. Just like EEG, we have a smaller area which can be delineated, which is the causative of seizures, just like EEG, which delineates a wider cortical onset zone. So the main reason we are here today is to understand the semiology of seizures and the practical, localization values of different symptomatology of seizures. So the purpose of seizure semiology is crucial to obtaining and confirming the proper diagnosis and localization of the seizure focus. And we have various investigations which are invaluable in helping localize the seizure focus. But if these tests are in discordance with the semiology, this raises suspicions about the accuracy of the localization. So whenever we plan to treat a patient surgically, we should have the concordance of the clinical symptoms, the EEG, and the imaging symptoms. When these three match, only then we go ahead with any surgical treatment of a seizure, epileptogenic lesion for a patient. There's something known as a pre-ictal phase of a seizure, which includes a prodrome or the aura. I'm just touching upon it so that we can talk in detail about the semiologies. Prodrome is a pre-ictal phenomena that heralds the onset of an epileptic seizure but does not form part of it. Headache, changes in mood or behavior, slight sleep disturbances, lightheadedness, anxiety, difficulty concentration, they all can encompass under a common terminology known as a prodrome. And there's something known as aura, which is a subjective ictal phenomena that in a given patient may precede an observable seizure, and they do have a localizing value. And so I told you that the aura do have localizing value. So it can be ictal sensory and experiential phenomena occurring at the beginning of a focal seizure and with preserved consciousness, exclusively subjective symptoms, and occur at the beginning of a seizure. They are the warning symptoms. They are subjective, and you cannot, you will only know when the patient tells you. So they are brief and only rarely may persist longer. And epileptic nature of aura-like symptomatology can be documented objectively only if the aura consistently involves into a dialeptic or motor seizure, or EEG monitoring demonstrates an EEG pattern during the aura. It is reported by 22 to 83% of patients. Longer the subsequent seizure, higher the likelihood of forgetting the aura. And it occurs more in the non-dominant hemispheric seizures and during the awake state. So we have the localizing and lateralizing value of these auras. The aura provides important localizing and lateralizing value because it gives us the relationship between the seizure zone and the epileptogenic zone. The localizing value of auras in identifying the most likely lobe of origin, as good as that of EEG and imaging. Most patients with temporal lobe epilepsy report an aura. The absence of an aura is more likely with bitemporal than unilateral temporal. And the patients reporting several different experiences preceding a loss of consciousness may raise concerns about possible non-epileptic events. So, if somebody is telling you that the aura which he or she has with different seizures are different at different times, then that may lead us to suspect that the patient is having something known as, previously we used to call it functional. Now we find it derogatory and now use the term non-epileptic events. So the different auras which the patient reports, which the patients have experiences about, the subjective experiences includes visual auras, which may include flashing light of different colors, circular, maybe sometimes crossing midline. They have a localizing value to the visual cortex in the occipital lobe. And it's mostly, when it is unilateral, mostly elementary visual hallucinations is there. Auditory auras, there may be positive auditory auras, including the buzz on the noise. They there might be patients who complain of loss of hearing totally, and they localize to the Heschel gyrus in the superior temporal gyrus, and posteriorly it can be in the superior temporal neocortex. I have a diagram in the later part of the presentation which tells us, or which summarizes all the different cortex of the brain which we can see, and the different symptoms or auras which it represents. We have olfactory auras in the form of unpleasant smells, and that can localize to medial temporal lobe or the amygdala. Amygdala again is very close to the medial temporal, gyri. The insula, which is just beneath the sylvian fissure, or the orbitofrontal cortex. Orbitofrontal cortex is that part of the frontal cortex which is actually includes the dorsolateral frontal cortex. Now we have gustatory auras also which the patient reports unpleasant taste, and that localizes again to the insula. We have somatosensory aura, which includes both non-painful and painful. Painful auras, we need to know that painful auras most commonly occurs with the posterior part of the insula. So this is a very important localizing sign, which is very classical for posterior insula. And the non-painful can occur due to the post-central gyrus, the gyrus just behind the central sulcus in the lateral lobe of the brain, and that which contains the primary sensory cortex. If bilateral, it signifies involvement of the supplementary sensory motor area. So there are autonomic auras also, in which the patient might have subjective sensation of palpitation, sweating, and goosebumps. Again, that localizes to insula, just beneath the sylvian fissure. We can have the patient can have subjective sensation of abdominal tenderness or nausea or some butterfly in the stomachs, which localizes to epigastrium along with hypersalivation. Now, this again all localizes to the temporal lobe, the insular and the insular opercular part. The opercular part in the diagram, I'll show you that it is just in the base of the motor cortex, just where the central sulcus is about to meet the temporal lobe or the sylvian fissure. The cardiovascular aura, they localize to bilateral temporal lobes. The respiratory auras of the feeling of apnea and choking again localizes to the insular opercular region of the brain. The affective or the emotional phenomena, including anxiety and fear, they both localize to the amygdala. Now, the amygdala, once we go further medially, when we cut the temporal lobe and go medially, the just in front of the medial temporal cortex, you have the amygdala, which is again part of the limbic system. And the fear again is localizing to the amygdala along with orbitofrontal cortex and the anterior singular gyrus. We have a feeling of deja vu. They have no lateralizing value, but a localizing value to the medial temporal lobe. And the patient may have subjective sensation of ecstasy, which again localizes to insula. Now, ictal, I was till now talking about the aura. Now I'll be talking about the ictal phenomenology, which includes motor or sensory or autonomic. The motor phenomenology includes the clonic seizures, the tonic seizures, the myoclonic seizures, the dystonic seizures, the atonic seizures, and the hypermotor seizures. Now, the hypermotor seizures most commonly localize to the most frontal part of the brain, that includes the medial frontal cortex. I would be showing you the videos related to that. I'm not going into repeating the same thing which I have been telling you. Just we need to just looking at this. We have the gelastic seizures. We know by our MBBS days that gelastic seizures localized to the hypothalamus. That's not the only area which results in gelastic seizures. Only in the children, when there are hypothalamic hematomas, we have gelastic seizures. But however, in adults, when we have gelastic seizures, there are other lobes as well. And these gelastic seizures last for a longer period of time, and they emanate more commonly from the temporal lobe and the frontal lobe. Now, similarly, during seizures, if somebody is crying, that is the dacrystic seizure. we have the hypermotor seizure, we have the automotor seizure. Now, simple seizures, myoclonus consist of jerky-like movements in the body. The tonic is a sustained contraction spasms of the body, similar to epileptic spasms, in which the whole, there is the whole axial skeleton also get spasmodic. Clonic is, there is a shaky-like movements, and tonic-clonic is including both the tonic and the clonic movements. And versing movements is something which is in which the part of the body is moving towards one side. Now, coming to the atonic seizures, in which you have there is a sudden loss or decrease in muscle tone involving the head, trunk, jaw, and the limbs. This should not be confused with what is known as the drop attacks, which is also known as the astatic seizures, in which there is a sudden loss of maintaining an erect posture, which can occur not only due to a atonic seizures, can occur due to myoclonic also or a focal tonic also. So somebody who is like in a erect posture and is not able to maintain it, and drops down, that is not necessarily due to the atonic seizure. It can occur due to a sudden myoclonic also jerk leading to fall in the ground, and these are known as the astatic seizures. I'll be showing you this video in which has been taken from one of the journals, in which you can appreciate this patient. So this patient was talking, and suddenly you see that she was communicating with the eyes to the nurse and the doctor, and suddenly she had a loss of tone of her neck muscles, and then she fell down. So this was something known as the atonic seizures. Coming to the tonic-clonic seizures, it has a tonic phase followed by a clonic phase. In GTCS, can be preceded by sporadic or irregular myoclonic jerks. In that case, they are known as the myoclonic, tonic-clonic, or the clonic phase, or by an absent seizures. In focal seizures, the bilateral tonic-clonic phases are typically preceded by other focal semiologies. When they occur at night and are unwitnessed or before its treatment, it may be impossible to identify the presence of focal signs or symptoms. Let me show you the video for this tonic-clonic movements. This is for the residents actually. There are oro-alimentary automatism, then which led to left head version leading. Then there was left arm clonic movements. Leading to the right upper limb dystonic posturing, left upper limb dystonic posturing. Now this is generalized bilateral tonic movements which is occurring in the patient. So tonic seizures is a sudden posture involving increased tone, resulting in stiffness or tense posture due to sustained muscle contraction that usually causes an extension. Involve one or more limbs, the body axis and the face. When bilateral, they must be symmetric or asymmetric. They may be symmetric or asymmetric. And unilateral tonic seizures lateralize to the contralateral hemisphere in approximately 90% of patients. The localizing value is poor, but we deduce that it is mostly from the mesial premotor and the primal motor cortices. So this patient suddenly had bilateral tonic seizures. There is sustained muscle contraction of the bilateral upper limbs, along with loss of consciousness, along with versing movements of the eyes, and then it stopped. There is something known as a figure of four sign, which occurs at the onset of the tonic phase, prior to the clonic phase in patients with frontal seizures. This semiology consists of unilateral tonic extension of one arm and tonic flexion of the contralateral arm, which assumes a posture of 4. It has a good lateralizing significance with the extended arm occurring contralateral to the hemisphere involved in the seizure onset. Now, this you can appreciate the figure of 4 in this video. The patient is lying comfortably, and now you can appreciate that there is sudden versing movements of the head, And then there is clonic movements of one side, tonic posturing of the left side. And there is an assumption of figure of 4 in this patient. This is localizing to the supplemental motor area of the brain. Now, version is unnatural forced or sustained movement of the eyes or the head or the trunk or a whole body to one side. Small lateral saccadic and clonic features can be superimposed during version. During head turning, the chin may move laterally but also upward or downward. Patient to rotate along the long body axis. Lateralizing significance varies depending on the type of version. If there is only eye version, it localized to contralateral frontal eye field. However, if the patient has initial visual hallucination, it can localize to contralateral occipital, and then it is spreading to the other parts of the brain. If there is a head version, we can only say that it is localizing to the contralateral hemisphere. Now, this is the picture of a patient with the concomitant EG which is running. And now we can see suddenly that there is a version of the head towards the right side, showing the ictal changes in the brain. Jaw is moving on the right side. There is dystonic posturing of the right upper limb also. So this is localizing to the contralateral hemisphere. Now there are seizures which have complex motor behavior also. Some may look involuntary. The patient has no capacity to control and inappropriate to the situation, can be mixed with elementary motor signs and may be associated with facial expressions and verbalization or vocalization congruent with the motor pattern. Due to a release phenomena of stereotyped inborn networks with fixed action patterns, or due to transient desynchrony in emotion regulation in networks. Now, coming to, we have talked about aura, we have talked about the ictal phenomenology. Now, let us talk about automatisms. What are automatisms? They occur commonly in patients of focal seizures. They are irrepressible, discrete or excessive, and repetitive single motor activity that often resembles a voluntary behavior. Appear to occur with a semi-purposeful act such as disrobing and manipulating objects or eating or writing. May consist of an inappropriate continuation of pre-ictal activity with the same or exaggerated speed or amplitude of the movement. Awareness is usually but not necessarily impaired. So this is the video in which you can see that there are some semi-powerful movement of the hands. The patient is picking up on the clothes, laughing inadvertently. Try to fidgeting. She's fidgeting with her thing she's wearing around her neck. Coming to the video on the right side, the patient is seen sitting comfortably, and then suddenly he has a snare and starts fidgeting with things and putting the thing on his hand in his nose. Now, there are automatisms which are oro elementary, like chewing, lip smacking, lip pursing, licking, and swallowing movements. They occur more commonly in temporal lobe seizures, usually mesial temporal structures. They can also involve the insular and the opercular part of the brain, and it is needed to facilitate their occurrence. Preserved awareness more likely from the non-dominant dominant hemisphere for language. Video is not very clear. Still, you can appreciate that the patient is having trying to kiss and having elementary automatisms. the chewing movements. She's trying to take up the hand of the clinician. There are hyperkinetic or the hypermotor seizures, which is excessive amount and speed of motor movement. There is increased rate of acceleration of ictal motor movement and appearance or inappropriate rapid performance. These seizures arise from the frontal lobe. The seizures arising from rostral prefrontal regions are the region where highly integrated behavior is predominant. From the premotor cortex produces more elementary motor signs. You can appreciate these hypermotor seizures, which might look as psychogenic with hypermotor features. However, they are actually real seizures, which are the hypermotor seizures, localizing to the most frontal aspect of the brain. There is something known as epileptic spasms also, which are sudden flexion, extension, or mixed extension flexion. The spasms involve predominantly the proximal head, appendicular, and truncal muscles and are more sustained than brief clonic and myoclonic movements, but not as sustained as tonic posturing, which may last 0.5 to 2 seconds. When unilateral or asymmetric, they point towards a lateralized onset in the contralateral hemisphere, but do not have any localizing value. They occur mostly in children. These are the spasms. This is known as something known as hyperexplexia. There is sudden spasm of the baby. There are localizing values even of the post-ictal phenomenology. They consist of neurological deficits or psychiatric signs. They are accompanied by diffuse or focal slowing or post-ictal generalized EEG suppression after the clinical seizures. Most post-ictal features last 5 to 30 minutes, while some symptoms may last longer. Prolonged post-ictal altered consciousness or prolonged post-ictal focal neurological deficit should raise the suspicion of ongoing seizures and non-convulsive status epilepticus. Unresponsiveness was the most common phenomena, may take seconds to minutes. The torts paresis occur after focal motor or frontal seizures, may last from minutes to hours. It lateralizes to the contralateral hemisphere, regardless of whether the seizure spreads to the contralateral hemisphere on surface EEG or not. Develops after ictal involvement of the motor cortex, most often in frontal lobe seizures. Sensory deficits following seizures have rarely been reported and can be missed if sensation is not specifically tested. I'm not going to show you the generalized semiology. We have the autonomic signs also, which can present in patients of seizures, which include ictal tachycardia, bradycardia, and asystole, arrhythmia, hypersalivation, coughing, apnea, tachypnea, changes in the blood pressure, hypothermia, neurogenic edema, and the respiratory depression, cardiac dysfunction occurring after GTCH. And they are critical factors in a sudden onset death in patients of epilepsy. The semiology of now these are the something wrong in my computer. Yeah. So eyelid myoclonus, eyelid myoclonia are referred to rapid eye blinking or flickering, trembling, fluttering, or twitching or jerking of the eyelids, often associated with sustained upward gaze deviation with or without absences in patients with G1 syndrome. You can appreciate baby with G1 syndrome having eyelid myoclonus. Now, there are something known as typical and atypical absence seizures also. Absence seizures should not be confused with atonic seizures. Now, these absence seizures are brief, generalized epileptic seizure of abrupt onset and abrupt termination, sudden onset and interruption of ongoing activities, often with a blank stare. If the patient is speaking, speech is slowed or interrupted. If walking, he or she stands transfixed, often associated with other concomitant symptoms such as myoclonia, automatisms, or autonomic disturbances. The most common manifestations are clonic jerking of the eyelids, eyebrows, and eyeballs together or independently, as well as random or repetitive eye closures. This is a child with typical absence seizures. She's asked to hyperventilate. Sudden absence, and again she gets back to normal consciousness. Again, this is a child with she's experiencing sudden loss of consciousness, not unaware of the environment. Now, there are something which is atypical absence seizures also. They have inconspicuous start and termination with the following. The clinical symptoms of mild to severe impairment of consciousness, often, significant changes in tone with hypotonia and atonia, mild tonic or autonomic alterations. They have a easy discharges of slow spike wave, which are often irregular and heterogeneous, and may be fixed with fast rhythms. They also invade the limbic areas. Now, I'm not going to talk about the absence seizures here in detail because they are more into talking about the generalized seizures. I'm here going to stick to the focal seizures and the localization.
Aditya,
Now, this is the diagram. Sorry,
the slides are not moving, Aditya. Yes.
is it okay now?
Yes, yes, yes.
Yeah, okay. So you can see now this is the lateral part of the brain in which you can delineate the sylvian fissure, the central gyrus, and just the gyri in front is the precentral gyrus, and they have symptoms of clonic seizures, sometimes tonic also involving the face and the arm. Just if we go to see the middle surface, this is being continued in the middle surface just above the cingulate gyrus as a precentral gyrus of the legs. So where exactly the tonic-clonic movements are occurring, where if it is in the face and the arms, it has to be on the lateral surface. If it is in the legs, we have to consider the homunculus in the medial part of the lobe, the paracentral lobule, right? Similarly, this is the central sulcus. We can delineate the post-central gyrus, in which the symptomatology will consist of the tingling and the numbness. Now, considering this whole part as the frontal lobe, this area just in front of the precentral gyrus is the frontal eye field. Once this is activated, it leads to the head and the eye version to the contralateral side. Now, this area, which is just at the junction of the sylvian fissure and the precentral gyrus, this area is the frontal operculum, and the frontal operculum leads to hyperclonic hypersalivation and clonic movements of the contralateral face. Now, if the Broca's area is involved, then there is symptomatology which involves the expressive language, but it occurs only in the dominant hemisphere. Now, this lateral part of the lobe is the dorsolateral prefrontal cortex, also known as the orbitofrontal cortex. If this is involved, there are complex automatism along with dialectic semi-purposeful behavior. Coming to the medial surface of the brain, here in the cingulate gyrus, or the mesial prefrontal area, both the areas, they involve, when they get involved, they lead to hyperkinetic ictal fear and the vocalization. Now, this cingulate gyrus has the anterior part, the middle part, and the posterior part. If we have patients with figure of 4 or complex motor seizures, we need to understand the medial surface of the frontal lobe must be involved, which is the premotor or the supplementary motor area. Now, this was all about the frontal lobe seizures. Now, if we come to see the temporal lobe seizures, The temporal lobe seizures, the common area. Now, this is the Heschel gyrus or the temporal neocortex. Once we start cutting the temporal gyrus and go just beneath the Sylvian fissure lies a very important area known as the insula. Now, this insula is also important in patients of stroke. I'm not going to talk about stroke here. Now, this insula, again, if we divide it into the anterior part and the posterior part, once the posterior part is generating seizures, there is a classical painful sensations, including burning and tingling. The anterior parts, once they get involved, there are many visceral sensations which can occur in the patient, including abdominal aura, laryngeal constrictions, autonomic signs. Once we again cut the lobe further and not going to the midline, but just, before the midline, we can find the mesiotemporal area, including the hippocampus, in which we have the behavioral arrest, the automatisms, and the gustatory and the behavioral psychic aura. In front of it is the amygdala, which leads to fear, tachycardia, apnea. All the symptoms are emanating from this side. Now, coming to the parietal lobe, we need to understand that once there is involvement of the superior parietal lobule, there is a altered body perception or out of the body phenomena may occur, in which the patient may feel that he can see his or her own body or the mirror of his own body. Now, there is something known as the parieto-occipital junction, in which there is the parietal lobe is meeting the occipital lobe. In this junction, if there is seizure is emanating from this junction, there is symptomatology of eye version and nystagmus. On the lateral surface, we also have the visual association areas, which leads to complex visual hallucinations, kinetopsia, macropsia, and micropsia, and autoscopy. Now, autoscopy is something in which the patient can see his or her imaging coming out of the body, and it also causes complex visual hallucinations. Coming to the medial surface in the next slide, if no, medial surface in this slide itself, if there is involvement of the precuneus, again there is altered visual perception. The images can be narrowed down or can be seeming like a miniature or in a larger size. And if there is a involvement of the primer visual cortex, there will be flashing colored or bright lights. Very important is to differentiate auras of migraine with these occipital lobe epilepsy, which I'll be talking about in one of the slides in the coming presentation. Now, we have to understand there are certain characteristic features of seizures emanating from different lobes of the body, lobes of the brain. Now, the frontal lobe seizures, you have to know that most of them occur, short-lived seizures occurring in clusters, most of them occurring during the night, and they represent 20 to 30% of all the focal seizures. Now, they're very short in duration and occurring in clusters, mostly during the night or early morning when the patient is in sleep. Dystonic posturing is a prominent motor signs. I have just dealt with someone patient who had no actually tonic-cloning movements, but every morning she used to have, most of the mornings she used to have tongue bites. And there was a EEG which was showing frontal rhythmic delta activity, and there were interictal changes of frontal lobe seizures. Now, these patients have frequent vocalization, stereotyped semiology, rapidly secondary generalizing, recall mostly present in these types of seizures. Now, again, if we go to define each area by area, which I had showed you in that diagram, there is when there is an involvement of the primary motor cortex, what occurs when the involvement of supplementary motor cortex, what occurs. I'm not going to bore the residents and the audience with the repetition of same things again and again, but this chart would be useful in again going through different symptomatology of the frontal seizures in different parts of the frontal lobe. Now, again, this diagram shows the same thing which I had shown in 2 slides before with a clearer picture. Now, this is the supplementary motor area. What exactly occurs in seizures of the supplementary motor area that involves arm, and head and eyes turn to side opposite lesions. Now, what occurs when there is involvement of the primary motor cortex, whether it is in the medial side or in the lateral side of the brain? What happens when there is the involvement of the postcentral gyrus? Now, insular epilepsy, I have been talking about again and again, that part of the brain which is just the area of the gyrus which is just beneath the Sylvian fissure. We have very unique features occurring in insular epilepsy. There is rapid propagation through extensive connection. There are a variety of visceral, motor, and somatosensory symptoms which mimic seizures arising from many other areas. There are typical ictal sequence of pure insular epilepsy consists of hypersalivation, laryngeal discomfort with thoracoabdominal constriction or dyspnea, unpleasant perioral paresthesias leading to dysarthria or dysphonia, and then focal motor seizures. Seizure restricted to the insular lobe do not result in impairments of consciousness. However, because it has a rich network propagating to other parts of the brain that involves the thalamus and the reticular activating system, there is consciousness which is impaired in insular epilepsy. Unilateral focal sensory and motor activity localizing to the contralateral epileptogenic zone. Once these insular region spreads towards the outer part of the brain, towards the opercular region, hypersalivation is very common, leading to choking throat sensation and perioral paresthesia, autonomic sensations like retching and palpitations, and sometimes variable semiology. So this is exactly the operculum and the insula, which is shown in the coronal sections of the brain. Temporal lobe epilepsy, these are epilepsies with a lot of behavioral arrest and cyclic phenomena. And these temporal lobe epilepsy generalize very rapidly because of rich connections. There are automatisms which can include oroelementary or gestural. They are repetitive, coordinated motor activity inappropriate to situation, associated with altered sensorium and amnesia. The stereotypic aura leads to ipsilateral automatism, contralateral upper limb dystonia, GTCS, and postictal confusion. Now, the hippocampus, once involved, leads to behavioral arrest. The insula leads to epicaustic aura and salivation. The operculum leads to oroelementary automatism. Basal ganglia leads to limb dystonia. The supplementary motor area leads to figure of four phenomena. The primary motor cortex leads to clonic jerks. If there is involvement of dominant temporal lobe, there will be ictal speech arrest. The post-ictal aphasia will last for more than 2 minutes and has a prolonged recovery. If there is involvement of the non-dominant temporal lobe, there will be ictal speech with quick recovery. Ictal smile, including spitting and vomiting. Bilateral automatism with preserved awareness. There is lack of seizure spread to dominant language dominant temporal lobe or extratemporal structures. In the non-dominant temporal lobe, there is periictal urinary urge or periictal water drinking. That prompts me to have some water, if you allow.
So maybe wind up in the next 5 to 7 minutes.
Yeah, sure.
Dr. Aditya?
Yeah. It'll take only 5 minutes, I think.
Sure. Thank you.
So, mesial temporal lobe epilepsy consists of aura, arrest, automatism, and amnesia. Now, different auras, we have different, area involved. So, I'm not going to delve into all that details. The parietal lobe epilepsy, the next most likely source of seizure after temporal lobe epilepsy and frontal lobe epilepsy. The focal awareness predominant. There is sensory aura which is predominant. The primary sensory area leads to sensory march or the Jacksonian march. The secondary sensory area is without sensory march, and there is illusionary ictal palsy. May have no parietal symptoms, but rather manifestation resulting from spread to occipital, temporal, or frontal area. The only thing we need to remember in parietal lobe epilepsy is the superior parietal lobe, in which there is altered body sensation. The occipital lobe epilepsy, there is 5 to 10% of all epilepsy. We have visual hallucination in 20 to 70% of cases. Brief multicolored shapes. There are visual illusion. Blindness is a negative phenomena. Again, bilateral blinking or eyelid fluttering, superior to calcarine fissure, spread to frontal regions. Post eye closure, we localize to calcarine fissure, and these also spread to the frontal region. The nystagmoid eye movements localized to the parieto-occipital junction. The eye deviation to the contralateral side, again parieto-occipital junction. This is the important slide in which we can differentiate between the occipital lobe epilepsy aura and the migraine aura. So migraine aura lasts more than 5 minutes, around 5 to 30 minutes. However, the occipital lobe epilepsy aura lasts less than 2 minutes. The migraine is gradual onset and offset, but this is very rapid. Migraine mostly consists of black and white lights. They're very rarely colored. However, the epilepsy auras are mostly colored. There are zigzag patterns in the migrainous aura, which is actually circular. You can see circular auras in the occipital lobe epilepsy aura. Migraine aura, they are very less frequent. They are high and multiple times a day. So the take-home message for today is listening to the patient and witness is important. Aura is often the first clinical manifestation, which is subjective manifestation, important for localization of the onset of seizure. Semiology in children often varied and difficult to characterize. Video easy and capturing attack is convenient way of proving that is important for prognosis and choosing accurate drug. But there are different drugs which act with different efficacy in different types of seizures. Thank you so much.
Thank you, Dr. Aditya. Wonderful, nice presentation. We are knowledgeable after your presentation. So over to chairpersons for their opening remarks.
Sure. So
Questions are invited in the chat
Can you
box.
take up the questions one by one to Dr. Aditya? Sriraj?
Yes, sir, sure.
Over
Thank
to
you, Dr. Aditya, again for the comprehensive presentation. I think it was wonderful listening to you, and you had pretty lot of informative slides as well. We do have a lot of questions from the audience. I will go with the order of the questions which are put on the chat box. The first question by Dr. Rajiv, he asks about the RTMS. He asks if the advent of RTMS and other modalities of addressing the issues in the brain, has the surgical intervention become more or less obsolete? Yeah, the question is more about the intervention, but yeah, I will leave it to you to take the questions.
So is it me who has to answer this, right?
Yes, sir.
So
Yeah. All the questions have to be answered by you only.
Well, let's be very frank. I have not much exposure to RTMS still because I am an avid private practitioner. I am not associated with any institutional practice right now, and RTMS is rarely used in epilepsy treatment in any private practice. So I'm not the right person to answer this. Still, I know that RTMS will not take over surgical treatment of epilepsy yet, because if there are prominent epileptogenic lesions which is present in MRI, I don't think RTMS can replace that the surgical removal of the lesion.
Fair enough.
If we can have some inputs from the house also, the esteemed panel, I think they can throw more light and like it would really help the.
Nishan sir.
Yeah.
Nishan sir.
Yeah, actually, you have to.
I think Nishan and Sriraj both work in this field.
Actually, we've been working in epilepsy clinic and we do get resistant epilepsies, particularly cases of resistant epilepsia partialis continua, where surgical treatment of epilepsy is actually the treatment of choice and it does lead to improvement.
Yes.
So this is one. RTMS, when it comes to, I have a little bit of experience of using RTMS as resistant epilepsy, which actually didn't work. So we tried inhibitory RTMS in resistant focal seizures in one of our MD thesis. The sample size was very small, but again, RTMS in epilepsy is still very investigational. Shiraj, you have to say anything about it?
Yes, sir. I think I agree with both Dr. Chaudhary and you. I think RTMS is primarily more of a symptomatic management. It's not going to be a long-term management if at all it has a role in any of the individuals. So I don't think it can replace surgical interventions wherever surgical interventions are required. Yeah, I think we'll move on to the Next question. This question by Dr. Chandramouli, who has been working in epilepsy clinic at CIP earlier. His question is regarding the symptoms of vertigo, dizziness, giddiness, whatever the word that we feel. So he asked if do they have any localization value? Is it localized to frontal or
See,
temporal? Um, or he also kind of refers to some of the textbooks mentioning that it can, those textbooks even says that it can be of hospital origin. Um,
So let me be very frank that whatever the vertigo or chakra or dizziness, now again these are subjective auras which the patient is describing. What objectively we cannot deduce what exactly the patient is experiencing. So what he describes, we have to go by what the patient is describing. Once we go by the textbook knowledge, we know that vertiginous sensations, they all vertigo per se is localizing to the temporal lobe epilepsy, right? However, it is very difficult what the patient is meaning to impart to us. Sometimes what happens is even if they are having some visual phenomena in which they are not feeling easy or they are feeling dizzy about what is happening, they might misnomer it as a chakkar or a dizziness. It can be some occipital phenomena which can occur. So it has a very low localizing value. However, if you go on to exactly pinpoint what vertigo is actually localizing to, it has to be temporal lobe epilepsy. I think.
uh, there's also another question about the versive seizures. Can they happen without loss of consciousness? Is the question.
So, was the events of eye and head in consciousness versus in impaired consciousness, what can be the localizing value? Now, the versing movements, it also depends where the version is involved along with dystonia or not. Where exactly it is ending also. So that also helps in whether it is a ipsilateral or the contralateral origin of the seizures. Coming to the next part, that carbamazepine group versus valproate group, which is better in partial epilepsies. Now there has been SANAD trials, SANAD 1, SANAD 2 with different anti-epileptic drugs. Always, partial epilepsies, carbamazepine has scored over almost all the other drugs. Now, even lamotrigine also scored, but there was a non-inferiority trial between lamotrigine and carbamazepine. However, lamotrigine has its own drawbacks that it cannot be started upfront, and it has to be, it has auto induction, and it has to be given very slowly, and raised, the doses has to be raised at a very slow intervals. However, valproate is a beautiful broad spectrum anti-epileptic drug with its own drawback, the drawback of the fetal implications. That is why, so if you go that even in the absence epilepsies in which we encounter in clinical practice, this is the drug of choice in childhood and the juvenile absence epilepsies. And it is a really broad spectrum anti-epileptic. Now, once we know that the childhood absence epilepsy patients, they have solved auto resolving phenomena after a period of they stop having seizures. However, the juvenile absence epilepsies, they will have continuing having seizures. So it is very difficult to delineate between these two, and sometimes I myself started a patient on valproate thinking that it is a childhood absence epilepsy. However, the patient, when she turned to 19, now the parents were more bothered about her married life and all that. So actually, we were giving her ethosuximide also, which is beautifully acting in absence seizure. But after tapering valproate, she again had a seizure. Now, it was very unfortunate on that part. So valproate is a broad spectrum anti-epileptic. However, in young patients, it has its own drawbacks. Uh, that is precludes us to using valproate in young patients.
Dr. Chaudhary, just I have a just a follow-up question to this particular part. Post SANET 2, what do you think is the role of brivaracetam or levetiracetam over valproate or carbamazepine in managing focal seizures?
So let's be very frank. Levetiracetam has a very good safety profile, as far as the side effect profile is concerned. Even only in patients of renal failure, they have reservations that because all the metabolism is occurring through kidney, they try to reduce the dosages in patients of renal failure. But practically speaking, even in those patients, I find it to give it, with the most carefree attitude, because there is one drug in which you can use them as a broad spectrum anti-epileptic, and every practitioner in the India now let me be very frank. When I was doing neurology, I told that epilepsy is the only science which is the most non-scientific science. It's only hit and trial, nothing else. Even the drugs, it has no basis. There's just epilepsy is only the area which doesn't need any rocket science. It is just a hit and trial matter. Let's be very frank. In my neurology colleagues and friends, they hate me because I tell them that what you. But let's be very frank about it. Now, if you don't get something is not working without you use the other medicine, but that does not downplay the effect of other medicines. In those cases, we try to individualize it. What are the side effect profile or what is not the side effect profile? However, in a clinical practice, brevacetine and levetiracetam, they have the best side effect profile, except the behavioral side effects in some patients with levetiracetam.
We can move on to the next question, Sriraj.
Yes, sir. Um, I think you tried to cover this question earlier in your presentation, but nevertheless, if you want to add on to anything, is there is a localizing value is the same across ages and gender? Are there any age differences or gender differences in the localizing value?
Now, this is a very difficult question to answer. Well, I don't find that age would change the localizing value of no any of the symptomatology. Well, I might you might get some paper who is talking about it, but I have not really
Like
actually.
more of a chance association, I guess. Yeah.
Um, yeah, there is also another question on treatment of typical and atypical absence seizures.
Is it same?
Now, it's I think I've talked the best drugs available for absence seizures would be lamotrigine, ethosuximide, and again valproic acid. Now, considering the age and availability of ethosuximide in India, it is available now. We have to choose what is best for the patient.
But I guess ethosuximide is still not that commonly and very frequently available in the country, right?
Yes, yes,
So in
absolutely.
that context, we have to give either valproate or lamotrigine in most of the cases, right? Yeah. Sriraj?
Yeah. There's another question on asleep seizures. Again, I think you covered after the question came up, but yeah, you want to add on to anything, sir, on the
On which
asleep
one, sir?
seizures and the sleep seizures during the sleep?
Nocturnal seizures, solid
So
sleep.
nocturnal seizures are, mostly they localize to the frontal lobe. They are a cluster of seizures which occur to the frontal lobe. They are classically seen in frontal lobe seizures, actually, the nocturnal seizures. And more, the patient might not complain, but the one sleeping with the patient, they witness. And sometimes they can have hypomotor seizures also, which can be very scary for somebody, some spouse of the patient. And these are mainly nocturnal. They can either be hypnagogic or sometimes in the early part of the morning when the patient is about to wake up.
I think the other question is about the behavioral arrest. Do you want to add anything? The
No,
behavioral arrest, right?
no, these behavioral arrests are mostly localizing to the temporal lobe epilepsies, commonly seen with the area involving the mesial temporal cortex and accompanying amygdala and the angular region.
Yeah, one more important question, I think, from the perspective of psychiatrists is about differentiating epilepsy from dissociative seizures. Um, how can we differentiate the frontal lobe epilepsy and dissociative seizures in the clinical setting?
So for that, I need to first be very my submission. What exactly do you mean by dissociative seizure? My question to the psychiatrist is.
See, basically, dissociative seizure, what people refer to is like seizure-like phenomenons or convulsion-like phenomenons, which do not have
Hmm.
an element of abnormal electrical discharges in the brain. We do come across such situations very often, and like dissociative seizures, or as you call it, PNES,
Hmm.
like non-epileptic attack disorders.
But now, so now the era is such that we still cannot call it, now the modality with which we are trying to diagnose things, they have their own setbacks. Now the amount of cortex which is needed to be picked up in a EEG is more, which we can detect now. Now there are cortical EEGs which can be done, stereotactic EEGs which can be done, magnetoencephalographic emitter. Until we exactly rule out the exact area, how can we downplay what is happening? How can we say that the electrical area is normal? Might be what we are telling it to be dissociative seizures, might be actually having a electrical correlate to the event or the phenomenon.
So, Vinay, why we mean, Aditya, by this is that in which then we'll start anti-epileptics, if from treatment perspective.
Now, again, I told you that because we cannot, we can miss a area through EEG, which can be picked up by stereotactic EEGs until the patient is not responding, and you have to give her a trial of antiepileptic.
Hey, I just want to a little bit of like my understanding, and I've been my practice over the last almost 15, 16 years now. So what in our clinical practice we usually do a video EEG, right? Then we have options of doing sleep deprived video EEG.
Yes.
Then another way is because most of the dissociative attacks or dissociative phenomenons where people are very suggestible. So what we try to do is we try to induce a dissociative seizure while the video EEG is going on, and we see that when a person is actually throwing an attack sort of a thing, that there is no electrical activity. Again, see, when you talk about EEG, it is not always because EEG is a temporal phenomenon. Like at times you might not get abnormality in EEG, even if in a case of epilepsy, right? Because
That's
most of the things are interictal. You already mentioned in your presentation. So that way, you know, some things related to semiology, something related to investigations, something related to behavioral observation of these cases might help us differentiating between a true seizure or a pseudo seizure, for that matter of fact.
Yeah, and I think the dissociative seizures are, we need not consider it to be a diagnosis of exclusion, as
Yeah,
well as mentioned.
exactly.
So it's actually a diagnosis where we can establish the correlation, usually with the stressors and other things.
suggestion actually helps. The suggestion, reproducibility of the suggestion, I think that really helps us. If we are talking about the non-epileptic seizures.
We do it pretty often because these days, adolescents, we do get a lot of such cases, and we do
We
do a
were
lot of
taught to use
simulations in them.
a tuning fork and a hammer to induce vibrations inside the brain to reproduce those seizures.
But at the same time, yeah, we also probably need to be aware that even the individuals who are having seizures, they can also be suggestible, and there could be dissociative seizures which will be happening in patients who are actually having epilepsy as well. So
That's what Aditya says, that there is always a gray area. You can't have 100% hit rate into all these things, right?
And also the
There are situations where people have both. People have epilepsy, long-standing epilepsy, they go on to develop dissociation. So again, that complicates the situation further, and such cases do land up with mental health professionals, particularly psychiatrists.
Just wanted to add one thing. Data I remember from my MPG days. 33% of patients of epilepsy also have pseudo seizures.
Absolutely, more than that, boss, more than that.
So yeah.
Aditya, if I'm not wrong, in single EEG record, you can have in non-epileptic discharges and epileptic discharges in the same patient,
Yeah.
the same recording.
So there are n
And-
number of permutation
And
combinations.
I'm still, I don't like pseudo seizures. I like PNES because I have great respect for people who might not have an electrical discharge, whom you might call it dissociative seizure, but there must be some neurochemical basis for whatever is happening.
No,
You're
that is
saying-
there. That is always there. So
You're saying everything
every
is
psychiatric
disorderly.
problem has a chemical or a neurochemical or a there are hard neurological signs these days. So that is fine. Can we move on to the next question, Sriraj?
yeah, sure. Clinically focal onset seizures, but EEG shows general interictal discharges. What it should be considered as focal or generalized seizures? Okay, the question probably is like you see focal onset seizures on based on your history, but when you're looking at the EEG, you might be seeing the generalized intraictal discharges. So,
I showed you the classification of seizures.
yeah.
It's focal seizure. We look at the symptomatology. Okay. And EEG is the next thing we do, but what we are classifying seizures only according to the symptomatology. The focal onset or a generalized onset, unknown onset.
There's a question on RTMS. I think we'll skip that. And the next question is on bipolar disorder, be a type of emotional seizures or limbic seizure, as antiepileptics decreases the symptoms. Yeah, I might not want to pose that to Dr. Aditya. Rather, if anyone else want to take up the question, or we'll.
We can request Dr. Shobit to answer this question. Dr. Shobit?
I think you only taught us the model of kindling. So kindling, they took it from epilepsy and then extrapolated to bipolar disorders, basic ganglion involvement, subsequently anti-epileptics helping up, and then various phenotypes in bipolar disorders where anti-epileptics might work and non-anti-epileptics might work. I think that answers the question.
Great. Yeah, very, very true.
I have a question. I wanted to get that. I keep asking neurologists, how do you find levetiracetam and its behavioral issues? Do you see there is some truth there? One. And is brevicetam better than levetiracetam?
When it comes to behavioral activation, right? This is the question.
Yes.
So,
Yeah.
some patients are there who do have behavioral effects. They do have, but whether brivacettam actually decreases those effects, I cannot tell that because they continue to have that even if we switch on to brivacettam.
Very true, very true. बॉस आपको पता नहीं बिकॉज और जैसे बिहेवियर सिम्टम आए दे कम टू साइकेट्रिस्ट सो मोस्ट ऑफ द न्यूरोलॉजिस्ट दे डोंट गेट टू सी दैट it's a very very debilitating side effect of levetiracetam, and you are very right, it doesn't get better with brivaracetam, so it just doesn't get better. So but we see in our epilepsy clinic, we invariably 70% of the patient who are on LVT, they do develop behavioral activation, particularly when it is started in young population, like particularly children and adolescents.
And boss, Nishan boss, have you tried switching to valproate?
Sir, वही करना पड़ता है at the end of the day. We
That
have
works,
to either
right?
switch over to broad spectrum anti-epileptics or maybe like valproate, carbamazepine or whatever of that sort. Yeah, we have to do that.
Sir, a question to Dr. Aditya. Dr. Aditya, there are a lot of practitioners in the audience. So can you tell us any method to madness? You said ki, okay, it's not a rocket science. Someone comes with temporal lobe epilepsy, then what drug you will start, and then patient has a poor response, poor control of seizures. Then what will be the what will the semiology of drugs you will follow? Antiepileptics like this on calcium channel, sodium channel, AMPA, whatever it is. So what is your rhythm of it?
Even today, if patient is young, though we say that the best control occurs with carbamazepine, I would like to start on levetiracetam because again the side effect profile is pretty low. Now they have actually not only because of their marketing strategies, actually you feel safe, with because in our population we cannot do the HLA typing of patients of carbamazepine. We have to rely only on the symptoms of. You have to tell the patient आपको rash होता है तो आप बंद कर देना. Sometimes they don't understand what you're trying to speak. So to be on the safer side as a practitioner, you always tend to start on levetiracetam. However, we know that if cost is a constraint, carbamazepine has no other substitute for partial epilepsy.
So it doesn't,
Carbamazepine,
there is a poor seizure control levetiracetam, then what you will give subsequently?
carbamazepine, of course.
If poor control, then
If poor control, then I will think that now he's going to have resistant epilepsy. I will tell him to go to a comprehensive epilepsy center.
Comprehensive evaluation. Fair enough, boss. Fair enough. Can we have a couple of more questions, Sriraj, because we are approaching 9:30. So maybe a couple of more questions we can take.
Yeah, there is one question on lateralizing value of ictal or post-ictal dysphasia.
Maybe your thoughts, Dr. Aditya?
Wait. Ictal?
Or post-ictal dysphasia,
Post-ictal dysphasia.
speech, I think.
Now again, dysphasia again occurs only in the, mostly in the dominant lobe motor area, the language area, the Broca's area, expressive language. We need to consider the involvement of the dominant Broca's area.
Dominant lobe. Fair enough, boss. Very nice. maybe some
I
more
think we can
questions.
go to the last question. We have a 4-year-old boy treated with sodium valproate for 1 year focal partial seizures, perioral movements with lip biting. After 1 year, developed repetitive aversive movements of lips, now managed as query valproate-induced stereotypic movements by tapering valproate. The stereotypic movements are a side effect of sodium valproate.
But I have not encountered. See, first of all, I don't treat children. I am into adult neurology. I don't encompass on anybody else's field of work because I am not an expert in pediatric epilepsy. But still, I can say that in adult epilepsy, I have not encountered valproate-induced stereotypic movements very commonly. Okay. But if somebody has, I cannot tell that.
Fair enough.
There's also a
So
question on cannabidiol in focal seizures. I think that's something which is
It's still
emerging with this.
it is still coming up. Still coming up.
and it's very costly also, if I understand. One bottle costs 10,000 rupees.
Yes. Yeah.
Migraine, we are talking about CGRP antagonist.
Yeah.
I was outside India for 1 year. They are using it left and right. Nobody talks about any of the migraine drugs we give out in India. They are only talking about different kind of CGRP antagonists, be it injectable, be it oral. They don't know anything about amitriptyline or beta blocker right now.
Oh, just learning.
So
There is one more issue, Dr. Aditya, if I can ask last question, maybe from my side also. Like at times we do encounter people who are on carbamazepine or oxcarbazepine, they develop either myoclonic like phenomenon or tick-like phenomenon after a prolonged use of carbamazepine or oxcarbazepine. Have you encountered such situations in your clinical practice?
no, actually no. Actually no. Let's be very frank.
Okay, okay, okay.
So
Because in
how
our
do we,
clinical practice, once in a while we do, encounter such situations. So that's why I thought that maybe if you have got it or not.
You must be having a greater pool of patients, sir, because you are sitting in a center with huge number of epilepsy patients.
Yeah, true, true, true. Great. So, Shiraj, can we wind it up
You
then?
can, yeah, I think I will request you to give the concluding remarks, sir. And
Thank you. Thank you. So, thank you very much, Dr. Aditya, for so
My
nicely,
pleasure.
putting across the presentations of focal epilepsy as well as encompassing generalized epilepsy also in between. I'm sure it will be very, very helpful for all the people who have actually joined today's webinar. And as I said that psychiatrists cannot get away from understanding and practice of epilepsy. You do come across cases every now and then. So I would like to thank the organizers, the team led by Tufan Pati sir, for having this topic in Thursday Musings, particularly for psychiatrists and mental professionals. So with this, on behalf of the chairpersons, I would like to once again thank all the members of Thursday Musing, Tufan Pati sir, Aleem, Amrit, Vishal Boss, and Shobit. With these remarks, I would like to hand it over to Tufan Pati sir. Actually, sir was traveling. So, sir, can you give some remarks from your side? Over to you, organizers. Thank you so much.
Any
Thank you.
concluding
Thank
remark
you, sir.
from
Thank you.
Dr. Sriras as a chairperson?
Yeah, Tufan sir,
Yeah,
just one
yeah.
question. So suppose we lateralize and we localize. So does it affect our choice of therapy, or every focal seizure will be treated the same?
Dr. Aditya?
Aditya bhai.
So that will not affect our choice of therapy, sir. Let's be very frank. That do not affect our choice of therapy at all. Because no matter it will, as far as the drug treatment is concerned, the localization and lateralization is only important once we are dealing with refractory epilepsy, in which we are considering surgical treatment or neuromodulation as our therapy, where we want to target the area where it is coming. However, once we are going ahead with the drug therapy, I don't think that would dictate our choice of therapy at all. And before I forget, actually, I want to thank all of you because it has been after a hiatus that I have been talking to a group of people. Thanks to my colleague and my brother, and he's one of the reason I'm here. Actually, I wouldn't have taken up this assignment. He told me that it was after a long time, and I'm really wonderful to be with people like you. And it was a wonderful 1.5 hours. Looking forward to meet again, and I'm really thankful from the bottom of my heart.
Thank you, Aditya. Thank you. Over to the Tufan sir. Sir, your final comments, and you have to say thanks also.
Thank you, Dr. Aditya, for a nice presentation. I'm sorry for a time I was off because I went transit, and by the time I migrated to this platform, it took around 10-15 minutes. It is a wonderful talk. And my simple comment, personally, I don't find at the basic level there is a difference between whether we consider the neuronal causes or psychological causes or chemical causes. It is there. The substrate is the same, neurochemical.
Absolutely.
So it is our limitation that we are not able to look at the things as they should, as they are. That is why science has to advance. This is where we stand. And because I am in practice for 40 years, I have seen many thoughts, many concepts coming and going. I have seen drugs being regularly used in our department, 5 anti-epileptics together. Phenytoin being the #1 drug. We have seen it. So this, but anyway, thank you very much. It is a illumination for the psychiatrists and all the around 200 people who had logged in. Thank you very much. I also thank all our vibrant moderators, Dr. Alim, Dr. Shobit, Dr. Amrit Patajoshi, and Dr. Vishal, and chairpersons, my dear CIP Digital Academy.
ठीक है सर, बोल
निशांत
आजकल
है,
आपका नाम
निशांत।
डिजिटल
लिख
एकेडमी
दिया
हो गया है. And we have worked a lot together on many platforms, and Dr. Siraz, and all the audiences over here. And on behalf of IPS Research Advent, I thank Torrent Pharma for furthering our march in this regard. And Nishant, thank you very much.
Thank you, sir.
Thank you. Thank you, sir. Thank you so much.
You deserve a proper name, not this common name. Good night,
Thank you.
everybody.
Good night to
Thank
everyone.
you.
Good night.
Thank you, Dr. Aditya.
Thank you. Thank you,
Thank you,
Aditya.
Dr.
Thank you,
Shah. Thank you,
Aditya.
Suraj. Thank you.
Everyone.
Bye-bye. Bye, everyone.
Ending the meeting now, sir. Ending the
Yeah,
meeting.
thank you.